So who all are answering today?
Good evening, sir. Myself, Ajin.
Sir, I
Chintan.
will be answering today. Yes, sir.
Okay, Chintan is there. Ajinkya is there.
I think Shashwat is also going to be there. He has not joined it.
Okay. So once all they join, just introduce yourself to Dr. Ganesh Bakshi also.
Okay. Okay.
Yes.
Sir, I'll answer. Rahul sir, you will be answering today? Rahul sir.
Yes.
Okay. So who else is now answering today? Rahul,
Sir, I am also answering.
Ajinkya,
Dr.
Chintan.
Anurag. Hello.
make Dr. Gite co-host and Dr. Huddedar also co-host. Okay.
सर मैं आपको होस्ट बना दिया हूँ एक्चुअली ट्रेन में जाने वाले नेटवर्क एरर हो जाता है
So I don't have to leave the meeting, na?
यस सर आई विल बी इन द मीटिंग सर बट आपको मीटिंग छोड़ना है लास्ट में 3 मिनट सेशन करना है मैं मीटिंग में रहूंगा आप बना
Okay,
दो
okay,
सर
okay. So good evening, Ganesh and Mahendra.
Good evening, sir.
Good evening.
Yes, their dates have come. I think their first exam is on, if I'm not missing, an 8th and 9th, na?
9th and 10th, sir.
9th and 10th.
10th.
Okay.
Okay.
I guess they must be already well prepared.
Yeah, they have all worked hard. Only their
They have
presence
been
of
reading
mind is,
also for a long time, I guess.
yes. And I think listening to our clinics and all, they are quite well prepared. Only thing is, whatever answer they give, they should have a presence of mind, number one, and the examiner should be ready to accept it. Sometimes they have got their own ideas.
So that time you
Gite
all
sir is
can say
there.
that this is my institution protocol.
Yes, that is true. And this time, I think even exams are in more center. Almost, I think 5 or 6 center.
Chalo, we start?
Yeah. Okay. Can we start then?
Yeah, pehla slide दिखाओ.
Gite sir has joined, na?
Yes, sir. I have joined, sir.
Fine.
Good evening.
I think then we
Good
should
evening, sir.
start now.
Yes,
सर
sir. Yes,
गीते सर को कोच बना दीजिए गीते सर को
कौन
गीते सर को
बनाने वाला?
बनाया नहीं.
गौरांग सर आप बनाने वाले because you are the host.
Okay. बाकी सब लोग हो गए ना?
Yes, sir.
Yes, sir.
चलो 58-year-old female presented with complaint of pain left flank 1 month. That's all?
Yes, sir. The initial history is this, sir.
Okay.
So we like to
और
evaluate
हिस्ट्री दिखाना है क्या कुछ ओडीपी वगैरह कि this is all we present with?
So we start with the
Ganesh,
one-line history and then
हाँ
build upon it, sir.
but we will not go much in the details of the history.
हाँ
like,
तो
you know.
दिखा दो वो पेन का हिस्ट्री
हाँ,
मतलब That's all
सब
right.
दिखा दे. Swastik, just show everything.
हाँ पेन का हिस्ट्री दिखा दो. So pain was dull,
Yes,
aching, insidious onset, non-radiating, gradually progressing, not associated with nausea, vomiting, no specific aggravating factors.
it was
Really
relieved
good.
on taking
At-
analgesics, sir.
क्या साइट लिखा था हमने फर्स्ट स्लाइड में?
Left side, sir. Left
Left
flank.
left flank.
Left flank.
The patient is a non-diabetic and is on tablet metformin 500 milligram BD. Family history was not contributory and personal history was she consumes mixed diet, appetite slightly reduced over last 1 month, and bowel bladder habits are normal, sleep is normal, and she was a non-alcoholic, non-smoker, non-tobacco chewer. Coming to negative history, no history of burning micturition, no history of fever, onset of pain, no history of vomiting, no history of anguria in past, no history of increase or decrease in frequency, no of urination, no history of facial puffiness, exertion, breathlessness, or lower limb edema, sir.
तो हेमाटूरिया क्लॉट्स भी लिख दें.
Next.
Loss of
No,
weight
sir.
loss.
No history of hematuria or clots in this patient, sir.
हाँ वो बात भी सही है. Whoever
Yes.
was saying no.
Yes, yes.
Technically it is very difficult, but generally ऐसा बोल सकते हैं. No history of weight loss वगैरह 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 whatever. But it's very difficult with this only history.
Yes.
So Ajinkya, you want to, before we go further, you want to ask any other question?
No, sir.
So history does not actually suggest anything. Left flank pain है. So what it would be? Genitourinary tuberculosis.
One is weight, decreased appetite is one positive finding. Otherwise,
It can be a stone disease also. Staghorn can
Yes,
also
sir.
cause pain.
could be stone disease, cystic disease, could be associated or secondary PUJ or
बराबर
GOTB.
secondary PUJ, adult polycystic kidney, the leaking pain. We go ahead. So remember, there are always differential diagnoses based on, one is that you are appearing for a urology exam, and secondly, the site of pain, along with negative history. So keep your, as Gaurang sir said, no presence of mind. If somebody does ask you, or most examiners will say, don't waste your time, come to the next step, which is examination.
Hello. Hello, sir.
Hmm.
Yes, sir. Sir, I am final year DNB surgical oncology student appearing for the exam. So in case of the left flank playing in other differential diagnosis, we have to say the colonic malignancies also, if it is just a
So
lacking
it can
pain
be,
in the
मतलब
left.
अभी बोल, मतलब you can't say, I mean left flank है तो थोड़ा सा tail of pancreas भी उधर आएगा, kind of.
Okay,
For
sir.
you know,
Yes, sir.
colonic आएगा, but a colonic causing pain, it will always have some associated bowel complaints probably.
So negative history, we have to ask for altered bowel habits or bleeding for rectum, sir, for the left
Correct.
flank pain.
Correct. Episodes of altered bowel habit, somebody tells you to elaborate, it will be constipation and sudden passing stools, whatever.
Okay, sir. Yes, sir.
There can be history of weakness with the anemia set in.
Yes.
Bleeding from the colonic mass or whatever lesion.
Yes. Yes, sir.
We proceed to examination. I think Mahendra joined, right? Dr.
Yeah.
Mahendra sir.
Yes, sir.
Chalo, on palpation.
I was just listening just to add that, as you said, just we have to think adequately with the history and the other point of the history and the different diagnosis and how to rule out. As
Yeah, rule out कर लेना, मतलब सब
yeah,
लोग.
as one person of surgical oncology said, do we need to enumerate all the organs? No, it is not a rule. You should correlate with the history, symptoms, and then decide what DD you have to make.
Yeah.
Yes, sir.
Definitely,
Only thing
presence
is,
of
as a
mind.
patient may, you don't have any other suggestive symptoms, so you can go in all directions.
Yeah.
Technically,
Yes, sir.
remember.
Yes,
Even
sir.
you can say,
Suggestive history hai, so we can go in a particular direction.
even you can say splenomegaly, anything, whatever cause can lead to any cause, dilating pain, maybe neurological, anything you can say that.
Yes, sir. Yes, sir.
But it is
I
not
hope
like,
everybody has read the general examination. It's normal. Next. Next slide, please. I think जो present कर रहे हैं तुम्ही पढ़ दो, I think.
Sir, yes, sir. So, on parallel examination, on inspection, abdomen is flat, central place and inverted umbilicus. Normal abdominal thoracic
Basically,
extension was
Swastik
there.
has covered all the points. Remember what all is written here. This is in short inspection. If there is any
Yes,
problem with you in exam talking, just imagine that you are looking at the tummy of your patient and, remembering each point like this.
Yes.
go through S-DAS for this.
But abhi to we are having a crash course in presentation now.
Yeah, just sir, just guide how to go into the exam. Examiner say, okay, just go to the directly. How will you proceed? Like that. But the proper way should be like this only.
Hello, Swastik, next.
yes, sir. So, inspection was grossly normal, sir. There was no hernia or an external genitalia was normal, sir, on examination.
Right.
On palpation, sir, normal temperature and no tenderness, no obvious palpable lump was present, no renal angle tenderness was there. Hernia orifices in normal, no cuff and pulse, external genitalia was no abnormalities detected, and spine no deformity. Percussion and auscultation was normal, sir.
So for the surgical oncology student, if there is a
Yes,
mass
sir.
palpable in the left flank or whatever in the left upper quadrant,
Yes, sir.
how will you differentiate between all the kind of masses? What is kidney?
Sorry.
What is colon? What is spleen?
Sorry, in case of the RCC mass, this renal angle dullness will be there because it displaces the colonic mass, matlab the colon on lateral side. In case of the differentiation between the renal mass and the splenic mass will cross from the LIF to the RIF opposite the midline, while the renal mass will not cross the midline. In case of the splenic mass,
I think थोड़ा सा vague answers मत देना. You learn to talk specific to your examiner. You know,
yes, sir.
Abhi, it's a nice opportunity for you to, if you have the knowledge, spill it.
Yes, sir.
ये मास में ऐसा है, एक में you started with percussion, dull note. Then,
Yes,
then
sir.
so you should have said colonic is tympanic.
Yes, yes, sir.
Some systematic discipline should be there.
Yes,
So
sir.
basically for renal mass which is palpable, okay, you can always
Yes,
insinuate your fingers below the costal margin, the mass is below. It
yes,
can
sir.
be ballotable or it can be bimanually palpable. It is dull on percussion.
Yes, yes,
Splenic mass for you specifically, it grows from the LIF, but you cannot insinuate the fingers and the direction. That's it. It's also dull on percussion. And colonic is tympanic. It is neither ballotable. It depends on the size. I don't know. It is not bimanually palpable usually.
yes, sir.
Chalo, next. Percussion normal, auscultation normal. So at the end of the case, we have not reached anywhere. So now I think let's discuss, right? So who's presenting today?
Sir,
So myself, Ajinkya, sir.
I will be presenting, sir, for this.
So
Ajinkya.
Dr. Ajinkya, Dr. Chintan, Dr. Rahul. There are two Dr. Rahul and one more.
Okay. So how will you proceed? Ajinkya, how will you?
Investigation, that is CBC create urinotin microscopy, and I'll also like to have an ultrasound abdomen and pelvis.
Okay. So you will do some basic investigations and top it up with the sonography.
Yes.
So for everybody, sonography is a simple non-invasive investigation, which in this type of a case will lead us probably to the possible diagnosis.
Yes.
So dikha do next set. Okay, 0.9 creatinine. So Ajinkya, since you asked for an ultrasound, ये WA क्या है? WA मतलब?
So whole abdomen, sir.
अच्छा, whole abdomen.
So we did not have a film of this patient, sir.
No problem. So lesion of right kidney,
Oh, sir, left kidney, sir. Sorry.
Left kidney. 3.6 by 3.2 centimeters. नहीं ऐसा टेंशन मत लेना स्वस्तिक. There are umpteen number of cases where there can be left flank pain and you find a lesion actually on the right side because the flank pain is an incidental symptom which attracts the patient to visit a doctor, and such masses are called incidentally found renal masses.
Yes, sir.
Yes, sir.
So that is the ultrasound. Who is next? Rahul. Who is Rahul?
Yes, sir.
Rahul, can you tell me what all you can get on an ultrasound and what are the advances in ultrasound in renal mass?
Sir, in ultrasound, if any lesion is there, we can know the site of the lesion, if the size of the lesion, the corticomedullary differentiation of the kidney, if there is any hydronephrosis present, sir. And along with it, we would also like to do a Doppler along with the USG so that we can see the vascularity of the lesion, sir.
Okay.
And sir, in recent advances, sir, we have elastography. We can see the elasticity of the lesion, which would more point towards a malignant lesion if the lesion is.
Okay. What more important things can be seen?
Sir,
One of the things you said, hydronephrosis, I agree it is seen on ultrasound, but in this type
yes,
of renal mass, it is of no great importance.
Yes, sir. Calcifications are seen, sir. And areas of necrosis may be seen, sir.
You can see if there is presence of any other masses along with this mass. You can see the presence of simple cysts. You can see, you can, if a good sonologist is there, he can check up with the renal artery vein. If there is a thrombus in the vein sometimes with that Doppler.
Yes,
okay. So when somebody asks you a leading question, you please go into it. What more ultrasound can give you? in an advance.
Okay.
If there is a contrast enhanced ultrasound with air
Yes.
bubble contrast, see, try to answer or think, scratch your brains. Think
Yes.
what case you are seeing and where you are going. Okay. I am sure you can always say ultrasound will see stone disease, this, that, वगैरह वगैरह वगैरह. But pertaining to this case, what more information? If say this patient has a creatinine of say 5, good test if available air bubble contrast is I can just give an air bubble contrast. Any point missing? Please point out that.
So examiner when asked about ultrasound, then he wants something more than the routine. Okay. So ultrasound with Doppler, contrast enhanced ultrasound and elastography. ये 3 things and उसके indications and importance. For example, if you are telling about contrast enhanced ultrasonography, sometimes it is better than the CT scan in case of the complex cystic renal masses or equivocal cystic masses. ये लाइन अगर आ गया तो एग्जामिनर को पता चलेगा, yes, he is knowing about the importance of contrast enhanced sonography. So Doppler already sir told कि renal vein thrombosis, ये सब चीजें क्लियर अगर बोल दिए तो जल्दी आगे चले जाएंगे. नहीं तो वही स्टोन, वही पार्टिकल थिकनेस, वही हाइड्रोनेफ्रोसिस बताते बैठेंगे तो वही गाड़ी का 5 मिनट चला जाता.
So remember all these things. Today we are discussing all this just to complete the list in a fast, rapid way for you. Okay. So next, what do you want? You have a 3.6 centimeter left renal mass.
Sir, I would like to do a triphasic CT of this.
You want to do a CT?
Triphasic CT, abdomen plus pelvis of this patient, along with the CT chest of this patient.
Okay. Yeah, good CT.
First take.
So directly chest बोलना उतना ठीक नहीं है because I don't know. मतलब the way we had an ultrasound report, it can even say if I say it is an AML or if I say it is something different, just I mean you can take a call. मतलब you can say कि I'll do a CECT abdomen triphasic or abdomen pelvis triphasic. As you are seeing, just these are some comments which I can tell you. मतलब.
But that means if it is a very big mass, then I think you can continue with the CT test.
मतलब एक allied question है कि up to 4 centimeter of masses, that is T1A, how much is a benign percentage?
20%.
80% around 60 to
80% are benign.
So that answers your question. We should not technically over investigate at the first go. देखते हैं जैसे खिलता है वैसे देखेंगे. Chalo, I think we can see that 3.6 centimeters lesion. It is in the right kidney only.
Yes.
Yes, sir.
So right is it.
Right.
Cystic ने वो सोनोग्राफी का लेफ्ट कर दिया था. मतलब बोल के राइट ही लिखा था.
Mistake हो गया था, but it is
So
right.
I think I did comment right. मतलब the left flank pain was just incidental. चलो, I think मतलब contrast films दिखा दो and if you are not spending time in reading the CT, then show the report. Or somebody, anybody of you for take a call, read that and tell us something.
Anyone wants to comment fast?
Yes, sir. This is a contrast enhanced CECT of the pelvis with axial cuts from upper chest to the pelvis in the plane as well as the contrast. Like the liver, the spleen, and the appears to be normal. The left kidney has prompt uptake of dye. There is no hydronephrosis or hydroureta on the left side. On the right side, the kidney, I could identify a well-defined heterogeneously enhancing mass involving the mid wall completely endophytic. more towards the pelvic, indenting towards the pelvic axial system, and
It is not totally endophytic.
okay, yeah, is in this, yes, partially endophytic, 50%.
Always take few minutes
Yes.
to read CT scan carefully before start describing it.
Yes, sir.
Make yourself relax like that. You know everything. See carefully and then speak.
I think fair, but it's quite a easy thing to say, huh? Matlab.
You describe very well the heterogeneous mass. Now describe the mass. And you were going right. If it is a small renal mass, then what you want to describe in this, like as a renal score, just go ahead
Yes,
with
sir,
that.
renal nephromatous scores.
हाँ तो
Go ahead
अभी
with that.
at a time when your exam is like मुंह पे ना ये points you should be ready with now. Should not forget these things now.
Yes.
Because this is what you have seen for 3 years. We have all discussed for such a long time. You have seen in various cases वगैरह. भूलना नहीं अभी. See, remember one basic fact. If you start giving all the answers, your case will progress logically to the end in 40 minutes, which will give you brownie points.
So renal nephropathy score comes out to be around 9P.
Next question, examiner will ask how. How it is 9P?
So for radius, it looks like around, it is less than 4 centimeter. Then it is partially endophytic exophytic, that is more than 50% it is endophytic. Then it is the nearness to the collective system, it is within the less than 4 mm from the looks like. Then it is more of posterior mass, and it is like in the mid polar region. So
Okay. Right. Oh, it is 10P. Okay, this is okay. Now, next question will be, what are the various scoring systems are there other than renal score?
So other than renal score, there is Cosmo score. Then there is zonal nephro score. Then there is DAP score. That is then there is centrality index, and there is arterial blood complexity index. These are the other scores available.
Some fat, gerotal fat.
Sir?
Renal fat, gerotal fat, which counts gender and the gerotal fat score, something called.
No idea.
So you should know
something
all
related
the
to Mayo. There are so many people here. We have discussed this Mayo something.
Mayo's
for IVC.
IVC classification, that is.
मैप स्कोर मेयो का ही है ना?
Oh, this is nephrometric score. Anyway, you should know all type of scores and which is most commonly used and which, okay?
Yes, sir.
And which is the more accurate. Okay?
Yeah.
I think at this class we are not going to describe everything. We are just going to guide you what to read and how to read and how to speak.
Guys, for those who are there, Mayo's adhesive probability score, remember, please. You must have seen your various bosses doing partial nephrectomies and sometimes the fat is stuck. So let's go ahead. So Mayo's adhesive probability score, remember.
Sir, in case UHG is like this, in this UHG it was not suggested, but in case you have an UHG which is showing heterogeneously echoic lesion and increased vascularity, that time we can ask CCT with chest X-ray or chest CT, or that time also we have to say again chest CT only. Sorry, only CCT to try, you cannot chest CT.
It depends on the language. A standard thing would be a CCT abdomen triphasic. When you come to surgery, obviously you will get a chance. Now, what will you do with a question? That time you can say, I'll complete my workup. If you see the NCCN guidelines, wherever they are, bladder cancer, kidney cancer, it always says additional workup. So I already threw that answer long back. If that 4 centimeter mass is benign, I don't think इतना debate होगा तुम्हारे एग्जाम में.
Okay.
तो ये हो गया है ना सिटी महेंद्र?
Yeah, Mahendra, you want to talk? Gita sir, you want to say anything about this other scoring system or something which is important?
नहीं सर, सिटी में अभी मास के बारे में और एडिशनल कुछ पॉइंट्स बोलना चाहिए, जैसा कि एनहांसमेंट कितना है, इंटरनल ब्लीड है, वाइट दिख रहा है, वो सेपरेट ब्लड सप्लाई है, कैलासिस दोनों अपर एंड में लोअर कैलासिस प्लेड होके कॉम्प्रेशन हो रहा है. ये सब चीजें छोटी छोटी है, लेकिन आप तुम्हारा माइन्यूट ध्यान है, ऐसा एग्जामिनर को लग सकता है. रिपोर्ट में नहीं भी दिया तो आपने को जो दिखता है वो फटाफट फटाफट याद करके सीक्वेंस से बताना चाहिए.
So that will give you upper hand.
Yeah.
Exactly.
अभी क्या करेंगे? 4 जन में से कोई तो बोलो प्लीज. What will you do next?
I would like to stage the disease and then do a metastatic workup of this patient by doing now CT chest if not done before.
ठीक है.
And LFT of this patient.
LFT is normal, CT chest normal.
I would like to, sir, counsel the patient regarding
LFTs, why do you want to see?
a metastatic site.
Okay, if you're referring to bone metastasis related alkaline phosphatase levels, so it is okay.
No, sir. Only LFT, sir.
ठीक है. और स्वस्तिक कुछ दिखाना है तो दिखा दो नेक्स्ट स्लाइड, मतलब if we have anything.
नहीं सर, इतना ही है सर. This is it for this case.
So consider all that workup is normal. Now what will you do? That is the question.
Sir, I would like to further counsel the patient regarding the state of the disease, the prognosis of the disease, and I would like to offer him surgical management for this patient. I would like to offer him, sir, open or laparoscopic or a robotic partial nephrectomy for this patient. And
Rahul, one of the favorite question, Rahul,
yes,
of the examiner. A patient is curious about this tumor is malignant or not, and he asks for the biopsy.
Yes,
How
sir.
will you answer that?
Sir, actually, in this CT, sir, if the contrast enhancement is more than 15 HU units, it's more suggestive of a malignant lesion. And for biopsy, the indication for biopsies are, sir, if multiple indication, if patient has been for active, we are planning for active surveillance of, or if we are suspecting abscess, or if there is multiple mets and we want to start some systemic therapy, or we are doing any cryoablative surgeries. On that time, answer, it would be indicated for a biopsy, sir.
Okay.
Sir, a triphasic CT is more sensitive and specific to identify renal masses, and considering its sensitivity, it is better we. I'll
Answer
explain
it.
patient it. That
Answer
it is there is
CT.
no need of
management.
not good.
Okay. ठीक है. Yeah.
So the sensitivity
CT, if it is
specificity,
equivocal or
the person who
any,
said na, ki does CT sensitivity specificity match with the MRI sensitivity specificity?
the CT is more sensitive in case of renal masses, sir.
Sure.
Or RCC. Yes, sir. For IVC thrombus, sir, MRI would be more sensitive.
If you ask a radiologist, they are damn sure about CT and MRI being equal, and they would already say that if I do an MRI, they would even tell us directly whether it is a papillary or a clear cell.
Okay, sir.
So in that, one tricky answer is that to identify the tumor thrombus, CT and the MRI are equal, but in presence of the IVC wall, Here,
Yes, sir.
MRI is more sensitive than the CT scan.
More superior.
Okay.
Okay, sir.
Yes, sir.
So only for the involvement of IVC valve, MRI is superior, and where it is contraindicated, CT scan because of contrast allergy.
So अभी जिसने आंसर दिया था I'll do open or lap or robotic. So
Yes,
बोलिए
sir.
आप कौन से रोबोट से ऑपरेट करेंगे?
Sir, I'm sir well versed in doing sir open surgeries. So if patient is very keen on,
Don't put that answer in the
yes,
exam now that I'll do open versus lap versus robotic. Because if I'm your examiner, I'll leave open, I'll leave robotic. I'll take you only on the laparoscopic partial nephrectomy.
okay.
Unless the examiner wants you to take you somewhere else, minimally invasive, why are you going there? You do what you think you can operate right now.
Okay.
Understood. Because it is easier.
I will do open partial nephrectomy with SOS consent of nephrectomy.
SOS radical nephrectomy.
Considering the Hilar lesion.
Any small thing in today's world you would like to do before this partial nephrectomy planning, which will help you towards the surgery?
The renal angio patient for
Renal angio, anything? Renal angio for what बोलो? Renal angio
so
क्या
for
तुम renal कुछ
Surgery
भी कर सकते हो? Renal DTPS स्कैन भी कर सकते हो?
renal vasculature.
And then
so for seeing
Reconstructive film for renal vasculature.
so in say no, इतना शर्म की क्या बात है? You should say
sir
in
if any
this type of
segmental
10 P
artery.
masses, it would be a blessing to do a reconstruction of this CT, provided this CT is a thin slice CT. If it is not a
Yes,
thin slice CT, that reconstruction is never going to happen. And a plus point today with today's technology is 3D printing. If available, such cases are ideal for these things. Outcomes always improve. Matlab, this is for you, it is going to be a theory question, but remember these things. 3D reconstruction of CT imaging, provided it is a thin slice CT versus 3D printing. Okay. So it helps you everything with knowing the vasculature, how it is in relation with the tumor, what am I going to damage when I'm going to enucleo resect the tumor. So all these things and a probable idea in my mind as to what reconstructive things I will have to do on that surgery. So if I go prepared with all these 4 points in my surgery, it is high chance that I might be successful.
So, Ganesh, two questions. Number
Yes, sir.
one, what is the role of nowadays DTPA renal scan? And second, in such cases, it is better to say in exam that I will also have per operative Doppler
Yes, sir. Per operative sonography, sir.
sonography, per operative sonography.
And DTP renal scan is not mandatory. You can generally take all the precautions if you want to.
Sir, guidelines has a specific absolute relative indication of DTPA scan.
So there are
That
two
only
absolute
that only
indications.
only those we have to tell in the exam.
Yes, sir.
That's all.
One is
Otherwise, if
solitary
somebody
kidney
say,
and bilateral.
yeah, if somebody say what is protocol in your hospital, that we can say. That's all.
Okay.
And regarding about the angiography, what is the advantage of angiography? You should do in all the cases or in selective cases.
So selective cases, especially if there is an IVC thrombus, we can get an idea about the extent of thrombus and cardiopulmonary bypass grafting if required in cases there
Angiography. I am not talking about the
also.
IVC thrombus.
Then we
I'm
can do
saying
it simultaneously along
in
with
this
that.
case, in this small renal mass, the role of the importance and benefit of doing angiography.
So if there is some segmental artery supplying the mass, then we can clamp the
So we
segmental
can
artery and then move
we,
So that would be one advantage.
Yes,
so we
In
can
whether
get
it is a
the idea about the branching and we can get the specific branch supplying the vessel. So we can go for this selective clamping or ligation of the branches. That is, we can go for a zero ischemia partial nephrectomy also.
very good. This is what you should answer like this. Okay.
And also exactly opposite, if you can see that the mass is very close or already indenting into the or
going into the vessel, into the up to the wall, you may consider it uh, as a radical nephrectomy because it is a hilar mass. So that is also one of the advantage of knowing the uh, arteriogram. Okay,
Yes.
fine. Okay, so finally, what was done, and then we'll go ahead, Ganesh.
Yeah.
Yes,
sir.
So in this case, partial nephrectomy robotic assisted was done, sir. Robot assisted partial nephrectomy was done, sir. And histopathology report was.
So, okay. So remember, the next question will be, tell me the step of NSS, partial, open, or robotic. How it is different from the open and the robotic. That's all. I think that is the only question the examiner may ask after this.
So I have a few questions to whoever will answer. So what are ways of how do you, if I have to do cold ischemia, please explain me one person. How do I start with inducing cold ischemia?
So after having the Euler dissection and after looping the both artery and vein, then we'll first clamp only the artery is clamped, and then after that we'll put the slush of ice around the kidney, wait for around 15 to 20 minutes, 15 minutes, and then once the
10 minutes. 10 minutes.
10 minutes, okay. And then later on we can start with the resection.
Yeah, later on you start with the resection, but you maintain ice on the cortex so that the kidney
Cortex, yeah.
keep
Yes, sir.
keep on cooling the kidney as you, because this is a complex tumor. It might even require 50 minutes or 1 hour sometimes. Okay. Now, second question is how to achieve hemostasis. What are different ways of achieving hemostasis?
So one is if you can see a direct vessel, you can directly suture it with an absorbable suture with 30 Vicryl or the PDS, and then with the rhinography, then we can have the we can achieve a hemostasis. And if there are small,
So
this is
you use 30 PDS very routinely?
No, Vicryl.
Vicryl, okay. So direct suturing of the vessel seen. That will be artery veins both?
So separately, sir. Otherwise it might lead to a AV fistula.
Okay, but when you do robotic, you do a full inner layer and full outer layer. So what is the difference between individual suturing versus bulk suturing? You said AV fistula, right? So AV fistula
Yes,
might
sir.
happen. What is the percentage of fistula?
1%.
5 to 10.
नहीं, इतना ज़्यादा नहीं है. 5 to 10 means every...
Okay. Sorry, sir.
1 to 2%. 1 to 2%.
1 to 1.5%.
Okay.
So suppose if your post-op report is fine, but suppose if I get a post-op report which says the same ISUB grade, कितना लिखा है ISUB grade? ISUB grade 2 and one margin is positive.
Yes, sir.
Focal margin is positive. How will you deal with it?
So if a focal margin is positive, sir, then we can observe the patient, sir, and we can keep him under continuous follow-up or surveillance, sir.
Okay,
Early
so
surveillance.
what kind of surveillance will do?
Sorry, sir.
What kind of surveillance will do?
Sir, first, after doing a partial nephrectomy, sir, after 3 months, we have to do one CT abdomen plus pelvis contrast and it's any cross-sectional imaging.
Okay, good.
And
CT or
then,
MRI we can do.
yes, a CT or MRI. And then follow it up with 6 monthly for 2 years, sir. Followed by 1 yearly for 5 years total.
Okay. Suppose if you open a calyx, are you going to put a DJ stent? This tumor is right in the center. You might even open the pelvis.
Yes, sir. In our institute, actually, whenever the calyx or pelvis is open, actually, we keep a DJ stent in situ, sir.
So we'll ask the next candidate. Does keeping DJ stent help or not help? What does literature say?
It helps in identification of open pelvic calyceal system while repairing.
So I think when he meant put a DJ stent, it was at the end of the surgery, na beginning में नहीं.
Yes.
So
No
identification is
significant
out of
Yes,
the
difference.
but
body.
we can put it, but it's
And
up. There is no fixed protocol.
Sir, in
it
some
does not make
center,
any significant difference.
Oh.
sir, in some center, people put electric catheter into the renal pelvis, and after suturing the pelvis, they inject the methylene blue to see the watertight suturing.
So literature says that DJ stent per se is not going to directly prevent you prevent leaks. I mean, okay.
Yes. Okay.
Okay. Mahendra, any other question?
No, sir, I think all practical.
नहीं मतलब follow protocol में question है follow protocol but interrupt any question?
No, a role of mannitol we can ask because it's a warm issue. If robotic open, we have choice of surface cooling in open. In robotic, it's a warm ischemia. Role of mannitol.
Can be given before clamping the artery.
Clamping the artery.
I said role of
Yes,
mannitol.
sir.
I did not ask when to give.
Okay.
So please listen the question carefully. I did not
So it
ask
is an
timing.
osmotic.
It causes diuresis and prevents the reperfusion injury and
The
the
question was
reactive oxygen.
not
Role.
pharmacological action of mannitol. Question
Okay.
was role of mannitol.
Okay, sir.
फायदा है या फायदा नहीं है, कोई स्टडी हुई है इसके ऊपर?
Simple.
That
देना
you
है
have
कि
to
देना
say.
नहीं है. This is what he's asking.
No idea, sir.
No idea, sir.
Discuss these points long back here. So literature now says that there is no particular benefit of giving mannitol. There are individual protocols or institutional practices where people give, don't give. If those who give 100 ml, usually. In that also some people give in the beginning, some people give in the end, some people give 50, here 50 there. But literature does say that it may not have any great benefit.
So this was the example. I am asking something, you are answering something. So be attentive what has been asked. Okay?
So one last thing is that ultrasound is necessary for such things possibly, like Dr. Gaurang sir had said. So remember that.
Yes, sir.
I think whenever you are describing about any small mass which is more of the either Hilar or endophyte, it is better that you talk of ultrasonography. That will be give you an upper edge. Fine. Can we go to the second case?
Sir, एक
Can I ask one
question और
thing?
पूछता हूँ इसको.
Sure.
You will cut the tumor with what? Cautery, harmonic, ligashure,
और कुसा.
किसने आंसर किया था ये? ओपन वर्सेस लैब वर्सेस रोबोटिक? राहुल
Tanvi, sir.
जल्दी बोलो यार,
Only,
फटाफट क्वेश्चन है, 20
sir,
सेकंड आंसर है.
You have seen them.
electrocautery.
You cut with what?
We actually cut
Says
with blades,
electrocautery.
sir.
Next person, what do you put your money on?
I was saying that electrocautery and any energy source should be avoided to prevent the artifacts for the histopath, sir. So actually we do it with the blade only. That's it. And then do a rhinography, sir.
I do it with a scissors, by the way, not blade. I don't know.
Blade नहीं. Blade से नहीं करते भाई.
Scissors.
Scissor. Sorry, sir. Scissor.
No,
Mark
no,
it.
is it not faster rule? Whatever you are comfortable, but don't use cautery.
Yes, sir. Histopath report might have some artifacts because of
Yeah,
that.
and scissor is why it is done. It is less traumatic and can be controlled well compared to blade. And the curve of the scissor may facilitate the follow the curve of the tumor as and when required.
Yes.
Chalo, next case.
Yeah. Swastik.
Yes, sir. So from the next case, we will have a short history and then we'll go to the investigation, sir.
Don't go into too much of history. Just
57-year male patient presented with complaint of pain over left flank for 1 month, associated off and on hematuria for 1 month. Hematuria is painless, intermittent, incomplete, associated with clots off and on, no history of fever, no history of lithuria, instrumentation time past, no history of weight loss, facial puffiness, lymphedema in the recent past. On examination, conscious oriented, afebrile, vitally stable, abdomen soft, non-tender, no abdominal lump, no bladder lump palpable. These were the basic investigations.
क्लॉट्स का साइज एंड शेप कुछ मेंशन है?
मेंशन तो नहीं किया
होना चाहिए, ठीक है। एमॉर्फस हैं, बिग क्लॉट्स हैं, ठीक है। कोई ट्रॉमा की हिस्ट्री, हेमेचुरिया है? नहीं है।
नो सर, नो हिस्ट्री ऑफ ट्रॉमा सर।
yes, Ajinkya,
Sir.
you want to ask any question final before just going into the investigation?
What about
past history slow on surgery on instrumentation?
Okay, ठीक है, fine.
No past history of instrumentation.
Okay, now. So directly we have gone examination and all is we are considering as a normal, correct? Swastik?
Yes.
Yes, sir, grossly normal, sir.
Yeah, and this is a sonography. If you can see properly and if you want to answer, say quickly, otherwise we'll go and see the report. Anyone wants to?
So static images of ultrasound, abdomen, pelvis, identify the liver. Zoom थोड़ा कम करो.
Why did you mention word static? CT scans are dynamic films, which you read
there. Okay, images, ultrasound of abdomen and pelvis, sir. Could identify liver, which is appears to be normal, then the I can identify right kidney. Could identify a hypoisoic mass involving the lower pole of the right kidney.
So the report.
Left kidney.
So in the impression, it is a well-defined, large, lobulated, heterogeneous mass lesion involving the mid and lower pole of left kidney, as described above, suggestive of left renal neoplasm.
Okay. So this detail of USG we have discussed in the previous case, what to see and other things. Now what next after this?
And you can see the mass, it is 9 into 8 point, almost 9 centimeter. Okay.
Yes, sir.
Yeah. So now tell us what you want to do. Rahul, what is the next? What would you like to do?
I would like to do a triphasic CT abdomen plus pelvis in this patient. Along with this, as it is a large mass, I'll do a CT chest along with.
Okay. Show the CT scan. So again, can anybody can tell on CT scan what things you want to see? An USG finding of left renal mass.
So first is the T staging, sir. I would like to know the size of the lesion, sir. If it is involving the PCS, sir. If there is any PCS, sir, if there is any IVC involvement, if there are any lymph nodes involved, if the other organs, if they are normal or not, or if there are any metastatic features, sir. And if there are
adrenal.
for
Adrenal
adrenal, yes,
and the
Renal opposite
contralateral
side
kidney.
kidney and the solid organs.
opposite side kidney.
And it better to say about the renal vein, not involvement, any thrombus in the renal vein or IVC.
Yes.
PCS can be involved or may have thrombus, and same thing with the IVC and the renal vein. Okay,
Yes.
fine.
Yes.
Okay. So what do you see in this case?
Left side, it's a renal vein looks, and that's
Only renal vein you can see, nothing else.
sir, IVC also, yes, sir, thrombus is there, sir, which is going cephal also and caudal also.
Okay, this film I cannot appreciate about cephal and the caudal.
Okay, sir.
Okay.
But IVC thrombus is there.
Okay.
Renal vein only, no, I think so, sir.
Okay. रिपोर्ट दिखा दो, रिपोर्ट क्या है और इमेजेस हैं?
Renal vein looks in.
I think once you all can meet your concerned radiologist and just to ask them how to describe the CT scan in short in the exam. Okay.
So the report shows that there is a evidence of heterogeneously enhancing soft tissue density mass lesion seen along the mid and the lower poles of left kidney. It measures approximately 9.4 into 7.1 into 10 centimeter. Partial exotic extension of the mass is seen. Fat planes and the adjacent organs are maintained. On post-contrast study, this lesion shows heterogeneous enhancement with few non-enhancing areas within. There is encasement with distortion and suspicious involvement of lower polar calyx, and this lesion also abuts the renal pelvis. Mild peripheral fat standing is seen, and tumor thrombus is seen within left renal vein, extending for a length of 4 cm up to the mid renal vein. No extension was seen into the IVC. Accessory renal artery is seen on the left side supplying the tumor.
Okay. So what do you think it RCC or TCC?
So this is a peripheral mass, so more suggestive of RCC. If it would be a more centrally placed mass, it would be more suggestive of a TCC, sir.
Oh, and patient is having
and
hematuria.
Thrombus and hematuria.
So why not TCC? Hematuria is a most common symptom of TCC.
The tumor thrombus is normally seen more in cases of RCC, sir.
Or?
And the location of the tumor, sir. There is no filling defect seen in the pelvis, sir, which would be more suggestive of a TCC, sir.
That is involvement is there, huh? Is it lower pole of calyx?
Lower polar.
Lower calyx mass going into the parenchyma?
Yes, sir, can be.
So? What you say it was correct because ureteral mass and pelvic mass, they don't have any parenchyma. So normally they do not maintain the you can say the well-defined structure. Normally these were so irregular. Okay. The second thing, they don't involve commonly going to the renal vein, and if it's renal vein, they are not localized. They are not such a confined masses. They are big masses involving the other structures also.
And one more is the enhancement of the lesion is more common in RCC, and TCC are more hypo-enhancing lesions.
Yeah. So you should know how to defend yourself. Even though if there is a doubt, suppose that, what will you do? Other than radiological feature, how can you differentiate between the TCC and the RCC?
Say step by step. If you are suspecting TCC, what other investigation you like to do?
then we will go for
Urine
cytology, urine cytology for few
Yeah,
consequently.
that is first. Second thing, what you like to do?
Then after that, we'll go for cystoscopy and look for bladder lesions, and then along with that, ureteroscopy. Since it is a pelvic mass, we will go for flexible ureteroscopy, and then we can, if from mass, we can take the biopsy also.
Biopsy.
Yes.
Okay,
So,
fine.
in such case, urine cytology or the biopsy, these are the
Yes, sir.
two things are there. We can differentiate this mass is TCC or RCC. If the cytology or biopsy it comes as a TCC, so whatever plan said by the other person is right. The cystoscopy to see bladder recurrence, but if comes as a RCC, there is a no role of cystoscopy.
Yes.
Yes.
Okay. Fine. Okay.
Fine.
Now what is the further management?
Further, after finishing the metastatic workup, sir, I would like to counsel the patient regarding the stage of the disease, the prognosis of the disease, and I would like to plan a left open radical nephrectomy of this patient with left open nephrectomy, open radical nephrectomy with 11th rib cutting incision.
11th rib cutting incision. Examiner will say that you have not seen any case with the left renal vein thrombus doing flank incision. I think even the book says that if there is a thrombus in the renal vein or anywhere, approach should be midline.
Midline.
Midline. Sorry.
If the thrombus is at the hilum, right side hilum, small renal vein and renal vein, then flank approach is okay. In left side, if again thrombus is up to only renal hilum, then it is okay.
Sure.
Because for this, your main purpose is to control the renal vein proximal to the thrombus first. Because if there is a dislodgement of the thrombus, what will happen?
Pulmonary embolism.
Okay, so how will you approach in this case? Chalo, I gave you a hint that you are going to. I'm not discussing about the DTP and the biopsy again. Already we have discussed. So making it short, how will you approach this case surgically? So flank approach only if the thrombus is over the renal hilum, where you can easily get the control of the proximal vein by the flank approach. But in such cases, it is better to go by midline.
Sequential.
Yeah. So how will you do that? The step of surgery in this case.
So we go with the midline incision. Then after opening the abdomen, we go for left colon mobilization medially. And then after that, we'll basically the vascular dissection we do. And after that, we'll ligate the renal artery, and then we'll sequentially, basically this is the tumor, the thrombus is extending up to the renal vein. So we can apply satin-C clamp directly on the IVC, and then after opening the renal vein ostium, we can remove the thrombus, and then we can do the nephrectomy.
Okay, so again, you're right. Artery should be taken first, and then apply satin-C or the endovascular clamp proximal to the thrombus, and just cut it and take it out. To avoid the thrombus spillage, once you cut the thrombus, either suture it, the cut end of the renal vein, or either apply another clamp on the renal vein to avoid dislodgement of the thrombus. What about the lymph node? What will you do?
So if there is any gross lymph node seen on the CT, or if there is any gross lymph node seen during dissection, that should be removed. Otherwise, lymph node dissection is not advisable.
So any indication where you will do LND in RCC?
Sir, this is a T3 lesion. and lymph nodes are positive,
N1.
so we can do in lymph node dissection in this case according to Blewett criteria.
So T3, T4, grade 3 and grade 4 lesions, size more than 10 centimeter. In case of
Sarcomatoid
if
differentiation and lymph
biopsy
node
has done a
positive.
sarcomatoid and lymph node N1 or lymph node positive.
Two or more than two, we go for lymph node dissection. Otherwise, we don't go.
So sarcomatoid things is the biopsy feature we usually don't have. So central necrosis, T3, T4 disease, okay, and presence of lymph node during the surgery. So definitely in this case, it should be done. Okay. So what will be the extent of LND in these cases?
So we'll do it from the diaphragm till the inferior mesenteric artery.
Pakka?
The crux of the diaphragm to the iliac bifurcation, sir.
Either or where ureter crosses the common iliac artery and interatocaval nodes. Okay.
Yes.
Okay. Fine. I think that's all. Again, follow up. What we have done in this case?
In this case, we
no, it was open.
Open.
Open nephrectomy, radical nephrectomy.
Yes, sir. Open
HPR, HPR.
HPR सर इसका भी available नहीं.
Okay, okay. So again, suppose that this is a level 2 thrombus, so level 3 thrombus. What would have a different from this approach?
If it is a level 3 thrombus, sir, we would also like to involve the GI surgeon for the mobilization of the liver. And sir, we would like to do a sequential clamping in this case, sir. First would be renal clamping, other opposite side renal vein clamping, and clamping about the tumor thrombus, and then opening the tumor thrombus, and then removing the tumor thrombus, sir.
Okay, okay. And what about lumbar vein? You will not take the lumbar veins?
We'll take the lumbar veins also.
Better. Whatever the IVC is between the clamps, you should take lumbar veins. It gives you bloodless surgery, near bloodless surgery. And if any large lumbar vein is there, their bleeding will continue. Okay. And what will be the sequence of opening of the clamps?
Same, sir.
Same, sir, what we
As
have
we have
applied.
applied.
First would be the infrarenal, then would be the opposite side, then would be the above.
Why?
First, we remove the infrarenal so that once the last knot is tight, before that, we would like to remove the infrarenal so that blood pools in and the air leaks out. And then we apply the knots over the IVC.
Okay. So now the question is there, opposite artery to be clamped.
Okay, sir.
And is it to be clamped? This is the question.
Will you clamp or you will not clamp?
Actually, question is very right. Because if you don't clamp the artery and clamp the vein, kidney will get congested and it may cause some other damage like that. He is right.
So, sir, if we are doing it for left side, that is left radical nephrectomy, we have to clamp the right renal artery also. But if we are doing it for right side, then we need not do it.
Why?
Because there is because the lumbar veins and renals are there, which can basically prevent the congestion on the left side kidney.
So it depends.
Lumbar are most common on left.
It depends where are you clamping the veins.
Okay.
So ideally, you have to plan in such a way that when you open the IVC and removing the clot, there should be not more than 20 minutes time over there. Clot when the suturing of the IVC. And Warren ischemia time, any kidney can sustain 30 minutes well, if it is healthy kidney. And always clamp the renal vein of the side at the last. When you mobilize the tumor, mobilize everything, then you do it. Okay? Yeah. I think Gaurang sir, anything?
Yeah. No, I think See, we are doing multiple cases. So,
Yeah.
like, in these two different cases, we have almost covered everything.
Only level third patient may require cardiopulmonary bypass, and it
Yeah.
should be done at high. If you say you have done any, you can say easily ki, yes, I have seen. This is the steps. If you not seen, I have not seen. Then be honest.
Yes, sir.
Only the thing is that depending upon the vein thrombus, what is the classification? And then we conclude here.
Two classifications of this, sir.
Yeah.
So one is level one
Mayo,
thrombus, one level one in which it is involving the renal veins. Level two it is involving infrahepatic. Level three retrohepatic, and above the diaphragms are level four. There is one more, sir, Mayo's classification, in which the renal vein involvement is level one. Above the renal vein in the IVC, less than 2 centimeters is level 2, more than 2 centimeters is level 3, and infradiaphragmatic, that's retrohepatic is level 4, and above the diaphragm is level 5.
Okay, anyone wants to add anything?
Sir, I think Mayo at level 0 is renal vein.
Sorry, sir. Yes.
0 to 4.
0 to 4,
Yes.
sir. Sorry, sir.
Fine. Okay. So let's go to the third case.
Yes, sir. So this was 70-year female presented with hematuria for 1 month. No known comorbidities. History of LSCS in past. Hematuria was painless, intermittent, incomplete, associated clots of phenomenon. The clots were amorphous. Yes, so the clots are amorphous and not very large. Sir. No history of lithoria, instrumentation history in past. No history of weight loss, facial puffiness, lymphedema in past. And examination was normal, sir.
Do you have urine routine and other things? Directly sonography.
In this case, sir, it was not done, sir. Urine routine was not done, sir. This was
fine. It was done, but it was not recorded. Okay, show them the sonography and then we'll go ahead.
Yeah, please go ahead. Anyone?
Any Rahul, please, either of you can answer.
OSG abdomen plus pelvis, sir. Showing so side, I don't know which side. The kidney shows hydronephrosis with a good corticomedullary differentiation.
Right
kidney.
kidney.
You can read right side, see?
Okay, sorry, sir. With bladder showing a hyperechoic right-sided hydronephrosis with no lesion seen in the kidney. In the bladder, sir, lesion is.
So you are able to see some lesion in kidney?
Yes, sir. A posterior wall more on.
In the kidney?
Kidney images.
Something at lower pole? The left kidney? The last image somewhere.
Yes, sir. Cystic.
Yeah, this one. The last something abnormal thing is there. Maybe I'm
lower.
I'm not able to make it.
Okay, anyway, Swastik, you can just show them the report.
So this was another film, sir.
Yeah. Now this you can see the bladder.
Ureter dilated up to the
VUJ, sir.
Yes.
Yes, sir.
Yeah. Okay.
So the report had the impression of left moderate hydronephrosis with proximal hydroureter. Right kidney was normal with moderate hydronephrosis and proximal hydroureter. There was discrepancy in the reports on the sides in this. ultrasonography.
Okay, no problem. So this is a report. It is not very conclusive, correct?
Okay, sir.
Yes, sir.
So what you like to do?
First, urine cytology of this patient, sir, and serum creatinine basic CBC and serum creatinine and urine cytology.
Yes, Swastik, what was the
Labs were
creatinine?
normal, sir. Serum
Okay.
creatinine was within the normal range.
Okay.
And urine routine was inconclusive. No malignant cells in the urine cytology was there, sir.
Okay. This is CT.
Sir, coronal sections of the CT abdomen pelvis look like the delayed images. Could identify the liver, then the left side kidney appears to be normal. There is prompt drainage on the left side kidney. On right side, there is hydronephrosis as well as hydroureter with some filling defect in the lower ureter. So, दूसरा वाला image.
Coronal section.
फिलिंग डिफेक्ट कहाँ दिख रहा है?
सर यहाँ कोरोनल
सर लोअर में इसमें
लोअर में सर कोरोनल सेक्शन
completely involved.
Completely.
Not filling defect. There is some hyperdense area, hyperdense lesion involving the lower ureter.
ऊपर वाला image.
Like some lesion in the lower ureter and there is no contrast there.
Yes, sir. Not the filling defect.
Actually, it is like two half images joined, and that is why you see something like that. But there is a mass in the lower ureter which you can see.
Yes, sir.
This is reconstructed film actually.
Yes.
Okay.
Yes. So now next, what you want to do? Show the report and then go ahead.
I would like to counsel the patient for cystoscopy biopsy.
सिस्टोस्कोपी फाइंडिंग क्या है?
So on cystoscopy, there was a small mass at the right VUJ, sir.
ये CT में
taken, but
CT के रिपोर्ट में there are no lymph nodes वगैरह reported.
Jara report, just show the report. Swastik, just show the report.
This mass looks clinically T3 for the ureter.
Yeah. Just show report, bata bhai.
1 second, sir.
You can read out also, no problem. So you asked for a urine cytology, right?
Yes, sir.
Yes.
And cystoscopy.
Yes, sir.
Suppose cystoscopy tells you that the orifice looks normal, the mass is just inside. Then how will we proceed?
Then we can do a non-traumatic, sir, URS biopsy of this patient.
And non-traumatic URS biopsy matlab? I'm sorry,
So
I don't understand.
how will you take a
Non-traumatic
biopsy?
URS.
So we can
So,
have
Dr.
one is either with the UCAT in the lower ureter. We can have a barbotage to the ureteric catheter and send for cytology. And second, you can have a flexible ureteroscopy and then take a biopsy.
एग्जाम में don't say you can have.
Yes,
You
sir.
cannot
I
say
will.
examiner you can have. Be careful.
Yes.
So if
So
you see
now-
that the bladder is normal here, and the lesion is probably in the ureter, then we classify it as upper tract urothelial. Am I right?
Yes, sir.
So what is the chance of having subsequent bladder tumors once you perform a ureteroscopic biopsy on a upper tract urothelial tumor?
15 to 75%.
10 to
75%.
75.
Yes, sir.
That is for the after ureteroscopy.
ये कहाँ से पढ़ा 75%?
मेरे को भी चेक करना पड़ेगा 75 कहाँ से आ
Check
गया
करना।
So
That is, I
he's
think, for
talking of
upper
upper
tract
tract
involvement
tumor.
with
75
simultaneous
मुझे भी
lower
पता
tract
था।
involvement.
He's talking of upper tract tumor coming to lower tract, not after ureteroscopic biopsy. Sir's question is after
No,
biopsy.
after ureteroscopic biopsy only. There is a chance of increased tumor. वो सीटी रिपोर्ट आया तो चालू करो।
Yeah. So CT is suggestive of, yes, Swastik,
Yes,
you can
CT
read it.
suggestive of ill-defined intraluminal heterogeneous enhancing lesion in lower third of right ureter, extending into VUJ, with perilesional fat standing associated with upstream moderate hydroureter nephrosis. The size of the lesion is 2.5 to 2.3 into 6.8 centimeter in the lower third of right ureter. There is moderate upstream upstream dilatation, as evidenced by dilated tortuous proximal ureter and hydronephrosis. Ureteric wall in proximal part of this lesion is not well delineated, likely periureteric extension. Right kidney shows delayed nephrogram. No evidence of radiopaque density noted in the kidney. No evidence of dilatation of left renal pelvis is identified. No areas of altered attenuation is noted in kidneys. No evidence of ureteric calculus or evidence of vesical calculus identified. The findings are suggestive of malignant etiology, urothelial mass.
Bolo bhai. Who is the fourth one who is answering? To Rahul, Ajinkya, and who is the fourth one?
Sir, Anurag.
No, the fourth one.
Sir, Anurag.
Okay.
Anurag.
Anurag is?
Yes, sir.
Anurag is there?
Yes, sir.
Okay. Fine, Anurag. So now you can answer. Now what you will do?
Sir, after this,
the question asked
we
is
will,
very simple. The question is that how will you proceed with the cystoscopy, ureteroscopy, and what are the different methods of taking the biopsy? You must have seen it in your institute.
Sir, first, after. Yes, sir. So, sir, basically, after this CT scan, we will go for cystoscopy. We look for any bladder lesion along with this lower ureteric lesion also. And then if there is no bladder lesion synchronously, we'll go for since this is the VUJ mass, we can directly go for a biopsy along with resectoscope also, or we can go for a ureteroscope and then take a biopsy. Now, biopsy we can do with either with a punch or we can do it with a laser.
Now, how will you do? As Dr. Ganesh Bakshi has said, if it is coming out, then it is
Yes,
easier
sir.
to take the biopsy. But if you have to enter inside the
Yes, sir.
ureter, if the mass is inside the ureter, how will you take the biopsy?
Sir, if the mass is not visible, we'll do ureteroscopy. After passing a guide wire, we go with the ureteroscope, and then we can take biopsy either with the biprong forceps, or we can do it with a laser.
Do you think that with the forceps it will be easier to get it?
Sir, better to so we can get it, but with laser it is easy. Sir?
Okay, so
You get a ureteroscopic cold cup forceps also, right?
Yes, sir.
So actually what we do is we have the domias with a punch, which acts like a punch, and we can, with that. So which ureterinoscope you will like to use?
So we'll go with the smaller one, the 4 French.
4 French, in 4 French, what you will use?
Biopsy बहुत छोटा है
Sir, नहीं.
Forceps will only not go in.
To see
There
whether
is
we
no
can enter
forceps.
it or not, and then we. Sir, basically to insert the ureteroscope, will first go with the 4 French and then followed by the normal 7.5 6/7.5 French. Ureteroscope will go and then take biopsy.
Okay. So what are the different ways of taking biopsy? So one is by the
One is,
domia.
yes, sir. We can use domia. We can do with a cold biopsy, or we can take it with a laser. While
Yeah.
laser
Hiren can
Laser,
explain
how
us.
will you take a
Dormia
biopsy? Laser, you will cut
with
a
the
tissue section, you are saying.
Yes, sir. We will cut and then we'll remove it.
listen
Suppose
with the
if the
dormia,
lesion
it's
is like
not
this seen
easy.
in this CT scan, it's occupying almost quite a bit. Matlab, there might be a very thin channel of ureter left for urine, and that is why there is a up track
Correct.
severe hydronephrosis.
See, if it is a papillary, fronded type of a growth, then
Dormia.
with the basket you can snare it.
Yeah, if it
But
is a
if
solid
it's a
growth like this, how will
if
you
it is
snare
a
it with
solid
Dormia?
growth like this, you cannot do anything with the basket. You need a cup biopsy forceps, and with laser, what you're telling, it is very challenging to do an en bloc resection and get it out. Laser, you should not tell. It requires a lot of experience to do it.
Oh,
And I
okay.
don't think this is a
Okay,
standard
sir.
indication of a laser thing.
Correct.
So your examiner
Laser
will take
nowadays,
you
you
on
are
the
seeing
urology
TUR,
viva only.
you are seeing TURBT being done by laser, so that's why you're telling, but not in ureter. Don't say it in ureter. En bloc resection
Oh,
of bladder mass is okay with laser. Many
okay,
people
sir.
are doing it, is okay to do it, but not in ureter.
Okay, sir.
Sir, want to ask one thing, sir?
See, the answer
Uh,
should be that I will go inside and see if there is a space, and if my laser, you can use a laser, you can see the tip properly, okay, the lower ureter. And if you are able to
Yes, sir.
take a small piece, is okay. Second thing is, if you have, see, everyone doesn't have that cup biopsy forceps. If you have that, that is also very good. And as Dr. Hiren has said very rightly, if it is not a solid mass, okay, and if you can take with the nomia, you can take that. The last thing is you can take the multiple pieces by your forceps. So whatever tissue you get, you can send it for the biopsy.
So what sir said is correct that many institutes don't have the cup biopsy forceps. You take the normal URS forceps, but be careful not to crush the tissue. You just pluck it and then get it out gently without trying to crush the tissue.
In this patient, considering the size of the tumor, it is 2.5 centimeter. One, it is in the it is in the ureter. Two, 3 is associated hydronephrosis. Then 4 is a cytology positive. So your ureteroscopy is going to change your management, ureteroscopy and biopsy.
No,
So
sir.
no.
cytology is negative, so that's why we planned for
Cytology is
ureteroscopic
negative,
biopsy.
and it is a 6
Cytology is
centimeter
negative, sir.
long.
So that's why, sir, we
So can
planned
we
for a
can we
ureteroscopic biopsies.
So
can we say like
doing
this?
the ureteroscopy when the lower ureter is completely packed with the tumor, how easy it is?
Very difficult.
Difficult.
So if you are discussing laser and all the ways of taking the biopsy, so as an examiner, I will not be happy.
That is what I said. You don't say laser. You just say you will attempt ureteroscopy and biopsy if you see anything.
Because in spite of that, if you are to tell repeat cytology or barbatus cytology, these are all non-invasive ways of diagnosing the malignancy, and the treatment for this site is already fixed. So just you have to just it is a low grade or high grade, and already site is there, size of the tumor is there, larger than 2.5 centimeter. If your repeat cytology is positive, your treatment is fixed. Radical nephrectomy is it going to change it? It will not
No,
going to change. और डिस्टल यूरेटेक्टोमी प्लस माइनस लिम्फेनेक्टोमी. सो ये चीजें फिक्स है. तो अननेसेसरी वो फिर वो क्वेश्चन आएगा यूरेट्रोस्कोपी कहाँ कौन से साइज से करेंगे, कहाँ करेंगे, ऊपर कितना जाएगा, ऊपर का नीचे कितना आएगा. ये सब अननेसेसरी का कंफ्यूजन में घुसेगा। फिर इंसिडेंस किसी को एग्जामिनर को पता है, तुमने गलत बोल दिया कि बिगड़ गई बात। तो use ureteroscopy when that ureteroscopy is going to change your plan. Otherwise, no ureteroscopy and biopsy. That's what I feel. गणेश सर बोलो सर, आपको कोई चेंज है तो?
नहीं, ये पेशेंट में तो ठीक ही है, मतलब मैंने वो टाइप भी किया है चैट में अभी।
हाँ, क्योंकि if same tumor is in the renal pelvis,
See, if
then
you have a
definitely
smaller lesion, it is a doubtful lesion with mild, moderate hydronephrosis, you go ahead with a URS related biopsy, no problem. Again,
agreed.
if you have, say, 1 or 2 lymph nodes along with this lesion, and I plan to give neoadjuvant chemotherapy for this lesion with this hydronephrosis, then I might do a URS biopsy of this lesion and then give, but I'll do a metastatic workup before that. I mean, and I'll give a NACT. And before NACT, then I want to know what is it. Rarely, it will be usually urothelial, as in bladder. Rarely, it will be something different. And that is why, because before NACT, I want to know the biopsy. So
Yeah.
these are some answers which you remember.
Correct.
These are
Yeah.
off-track
So
answers, but remember these answers.
correct. No, so that is why now, Swastik, anything
Sir,
else
one
was done or
question.
directly
Sir,
the
one
surgery?
question for Ganesh sir.
Sir,
Just for
Clear.
sake of discussion, Ganesh bhai, any role of nephron sparing? Nowadays, lot of discussion that because only lower ureter is involved, even though if it is high grade.
High grade में it is very difficult यार, अभी तक उतना
Yeah,
literature है ही नहीं. These are still rare tumors.
right.
And it is a long 6 centimeter. It is not only
Yes, sir.
2.5.
Yes.
And secondly, Hiren, ऐसा है ना कि nephron
No,
sparing
just for that discussion, I wanted to
for
raise a
discussion
question.
only I'm saying, for everybody, remember कि if we vary or divert too much from the set guidelines, like
Yeah,
set guidelines are probably what we were discussing and Gite sir was saying. If we are
yes,
digressing from that, you will have to add somewhere that in a multidisciplinary consult or a MDT board, something like that.
right.
So
Okay.
that decision is always after, consulting 3 proper people.
Correct.
Fine. So, Swastik, in this case, biopsy was attempted, but we could not get a biopsy, correct?
yes,
Just
biopsy
one
was
thing,
attempted,
sir.
sir, but we could not get that.
So one query,
So,
sir.
no. Okay. Query will later on.
Okay.
Let us finish this case, then all your queries. Fine.
And then, sir, we went
So,
ahead
what was
with the
done?
robotic nephroureterectomy, sir, with cuff of bladder excision.
Okay.
Yes.
And biopsy?
So this was the biopsy report, sir.
Can you read?
Yes, sir.
So your surgery is wrong, huh? Matlab, for urothelial, you should
Yeah.
never say, I'll do a nephroureterectomy. You will have to say, you will have to do the ipsilateral with a lymph node template. If you are going to say without lymph node template in a possibly urothelial carcinoma, as an examiner,
Yes.
that is incomplete management of
Exactly.
urothelial tumors.
So that is what we want, Ganesh. When we are presenting this, any case, we want the actual complete what the student
So
should
you will
say.
have to do open lap robotic is different. You will have to do right radical nephroureterectomy with, this is lower ureter. If it climbs to the mid ureter, accordingly 2 templates of lymph node dissection with bladder cuff excision separately. Separately matlab included a bladder cuff excision proper.
Correct. So that is the answer in the exam. All of you will give.
You say that.
Yeah.
But sir, if in CT scan there is a obvious disease, it's T3 disease, T3. Can you go to CT scan?
But please see the report also. Biopsy. Are they saying biopsy report also? Please see the biopsy report.
तो CT scan लगा है सर. महेंद्र है clinically T3, but then अभी तक मतलब the guideline about neoadjuvant chemo versus adjuvant chemo is still going on मतलब.
Yeah, and one question, sir, the pathology, this also was removed, right salpingo for ectomy. So what was the indication for that?
इधर है.
The second one, right salpingo-oophorectomy. Why was it removed?
बीच में आ रहे हैं.
Yes,
Okay.
so it was involved with the master.
No,
Not
but
ureteric
histology
case.
type is a squamous cell carcinoma.
Premarjuna is asking about POUT trial. So, Premarjuna, you only answer what is POUT trial. We have discussed it earlier.
Sir, it's an adjuvant platinum-based chemotherapy in a muscle-invasive
Correct.
node positive disease.
For node positive, for high risk, for what? T3, T4?
It's a
What is the exact inclusion in POUT?
non-metastatic, muscle-invasive or node positive disease.
Muscle invasive of ureter.
No, it's a upper tract TCC.
Correct.
T2 to T4, sir. I guess.
You are right. You
More than T2 or N plus.
Okay. Correct.
This case looks like more than T2 and so can...
No, but you read the histological type is squamous cell carcinoma.
No, not this case. If a TCC is there actually, then would have given or not adjuvant chemotherapy. Because your neoadjuvant and adjuvant, their clashing is going on. So shall we give any adjuvant chemotherapy for this case if it is a TCC comes?
Ganesh.
Yeah, you can give. मतलब मुझे लगा तुम आंसर कर रहे हो.
No, I want you.
So it is to be given within 90 days. POUT trial says that. ठीक है.
Okay. So if it is TCC, now in this case, when it is a squamous cell carcinoma, what is the importance of pre-op biopsy? Is there any importance or it is not important?
Technically not so important.
Not
Coming
so
to
important.
POUT trial, it is to be adjuvant is to be within 90 days. P-T2, T4 and technically N1, N3, P-T2, T4, NEN, I think. NEN, that is what I think.
Even in squamous cell?
No, sir, urothelial.
No, that's what I'm saying. But in this case, now we are talking of this case. In this case, the earlier biopsy would have helped us.
No, because we would have again gone for surgery only probably. Na? Squamous cell goes for surgery upfront.
Yeah. And in that, what about the lymph node dissection?
Sir, lymph node dissection is as per the template only. Matlab, it is not described in a squamous cell, but squamous cell again will most probably go to the lymph nodes.
Okay, so in exam, we have to answer the same thing.
So template dissection, earlier we used to believe that radical nephroureterectomy is accompanied by a complete lymph node dissection from diaphragm to bifurcation down. I mean, up to the external iliacs ending. So now it is as per the template. Lower ureter has a lower template. Mid ureter will have a middle template. Upper has a template up to the bifurcation of aorta.
Okay. And post-op, any radiation or chemotherapy in squamous? Because it is already going out.
So we can give chemotherapy, matlab, chemo radiation also we can give in squamous cancer. Squamous cancer main data is all extrapolated from head neck cancers, and for urology it is from penile cancer only. So technically chemotherapy and radiation can be given. But again, upper tract urothelial are rare cancers. In that, squamous is even rare cancers. So there is no great guidelines on that.
Fine. Now there are one question which has been asked that now this is a non-functioning kidney, so it is out of question. But suppose there was a function, and if you come to a diagnosis that it is a squamous cell carcinoma, can you go ahead with only uretrectomy and Bovary flap? And in that case, is it necessary to remove the cuff of bladder?
We can remove, sir, as you said, in a conservative manner because urothelial is totally different. It is a field change. If we know pre-hand it is commerce, it is different.
Fine. So if it is a small tumor, if it is a lower end, there is no need to do any cuff
No.
removal, and you can take a Boari and you can do you can do nephron saving if it is a functioning kidney, correct?
You can, sir.
Sir,
Because
only
even the higher grade squamous cancers, they need maximum 2 centimeter margin.
Okay. Fine. Just these are the different scenarios we want
But
you
again,
people
then
to know
in
it.
that case, we'll have to go in with a ureteroscopic biopsy and take a biopsy.
Yes, yes, yes. Fine. Okay. Anything else? So otherwise, we'll go to the fourth case.
Sir, in this case only, if
Yeah.
this came out to be squamous cell, but if we are suspecting TCC and HUN is present, so and we cannot take biopsy like this case.
So if
And cytology is
urothelial would
negative.
have been there, no, iska cytology would have been invariably positive.
Correct.
The another way, uh, if somebody asks the what else, it is like PCN and breast cytology of the mass from the pelvis for the
If it is
diagnosis
higher.
purpose. For diagnosis purpose, ureteroscope is not possible to do PCN and take a breast cytology from the mass from the above. That is the another way to diagnose the pathology.
Mahendra, लेकिन taking a biopsy of a lower ureter near to the bladder from PCN with all possible maneuvers, not too easy.
Sir, I am saying if somebody asks what else, easiest would be the uretero guided, but some examiners may dig, okay, how much you can think like that. So this is the last answer to be given.
I agree.
Fine.
Post-URS biopsy degestenting can be done. But again, all these procedures, they can lead to seeding of the disease in the bladder. Remember that whenever technically you are doing a radical nephroureterectomy, there is still somewhat evidence, 14% advantage of giving a post-op mitomycin injection. Again, remember that.
Yeah. Okay. So after doing the nephroureterectomy, it is better to do give the mitomycin.
Better. And as a practice, when you're doing a nephroureterectomy, if it is a really a upper ureter lesion or a mid ureter, then you can put a Hem-o-lok clip on the lower ureter so that the migration of cells is less.
Okay.
Any clip, or you can just tie with linen, yeah, no problem.
Okay, fine. So these are the 2 points you please remember, all the students. Okay, when you are describing in this case, then always put a clip below the mass doing the direction or resection. And second important thing is mitomycin. Remember these 2 points.
Sir, any role of DTP in this case? As CT was suggestive that left kidney has some delayed drainage, sir.
You can do, yeah, no problem.
You can do, but are you going to save this
So
kidney?
justify like this, that I see a gross hydronephrosis, see the creatinine value, I have joined, I don't know what is the creatinine value here.
Normal, sir, 0.9.
Normal technically. So I don't know how much far, because the other kidney looked bang normal.
Yes.
Yeah.
So I think if the creatinine would have been deranged, I would be in a favor of doing a DTP, and I would justify to my examiner like, yeah, I would like to know what is the GFR, accordingly use non-nephrotoxic drugs in a routine way. And very honestly, even if I have a one kidney which is normal, I'll try to use drugs which are good.
Fine.
Chalo, then.
Okay.
So adjuvant का मैंने वो link डाला है, but adjuvant pout में you can use either carboplatin or cisplatin depending on the GFR.
GFR. Fine. Swastik,
It's
can
the
we have
last
the
case, sir.
last case? Yeah.
So 66-year male patient present with history of intermittent hematuria for 3 to 4 months. So similar history, there is no finding on examination, sir, as such. The USG was this, sir.
Fine. So I think this is a very good ultrasonography. Please, one of you describe it.
Sir, ultrasound of abdomen and pelvis. The liver appears to be normal. The left kidney appears to be normal. The corticomedullary differentiation is good. On right side, I could identify an hydronephrosis as well as hydroureter up to the lower end of the ureter. And on the bladder images, I could identify a large broad-based uh, hypoechoic mass involving the right lateral wall of the bladder, sir. And showing some and look on Doppler it has vascularity also.
ठीक है, report.
So both kidneys were normal in size, shape, position, axis, and outline. Both kidneys show normal corticomedullary ratio differentiation. Right kidney was 10.6 and 5.4 centimeter, left 9.9 into 4.9. There is no evidence of mass, calculus, or hydronephrosis on the left side. No evidence of free fluid or abdominal adenopathy. Urinary bladder was distended. There is a 38 into 23 into 47 millimeter solid sessile lesion seen in the urinary bladder at the level of right VUJ. Resulted moderate right hydronephrosis and hydroureter seen. Another small 15 to 10 millimeter lesion seen near urinary bladder neck on right side. Both lesions show moderate vascularity on Doppler. Prostate normal in size, measures 21 gram. Bilateral inguinal hernia seen with herniation of bowel loops and omentum on valsalva, which is reducible. And liver was normal in echodection, no localized area of increased or decreased echogenicity in liver. Hepatic veins were normal, sir.
Yeah. So now tell us what you want to do.
Cytology followed
Rahul?
by a contrast.
Yeah.
Urine cytology followed by a contrast scan and CT scan of the abdomen plus pelvis.
Yeah. Cytology
After
was
knowing
done.
the serum keratin and CBC.
Swastik, show the results.
CT was done, sir.
This is a non-operated case. So we don't have all the information, but this is a CT.
स्वस्तिक थोड़ा दिख नहीं रहा है एक्चुअली बराबर. कुछ मैग्नीफाइंग मारना उसको. नहीं, वो कॉन्ट्रास्ट है उधर दूसरे साइड में. ये मैग्नीफाई हो सकता है क्या? ये मैग्नीफाइड है.
ये मैग्नीफाई किया है सर.
ओके ओके.
और भी मेजर
Lateral wall near UVJ or on UVJ there looks to be a lesion which is clearly seen because it is not, I mean I can't see more than this, but it looks like it has breached the muscle layer. To me it looks like that. I'm seeing a very small picture. And sonography said there were multiple tumors in the bladder, at least 2 of them. Right-sided hydronephrosis is already there, gross.
Yeah. Swastik, just read the report so we can go ahead.
Yes, sir. So the CT showed urinary bladder was well distended, approximately 55 into 20 to 26 millimeter size, multilobulated soft tissue density, 45 HU. Mass lesion was seen arising from right posterolateral wall of the urinary bladder. It shows moderate post-contrast enhancement up to 92 HU. Mass lesion is involving the right VUJ with resultant hydroureter and hydronephrosis. No obvious exophatic component is seen. The right kidney shows less parenchymal enhancement as compared to left kidney. Renal excretory function is seen in scan of 5 minutes. Left kidney is normal in size and shows good function. On injection of the contrast, pelvic calcium system appears normal.
Okay.
Liver is normal in size and shows heterogeneous parenchymal enhancement. No focal metastatic lesion in liver.
So what was the renal functions? CT के पहले creatinine कितना था?
Sir, normal था sir. It was 0.8 around. So the case has not been operated by us. Just came in OPD sir.
No problem. 0.8. So anybody क्या करेंगे?
Ajinkya.
Sir, we complete the metastatic workup. We like to have also the chest CT, and we like to go ahead with cystoscopy, cystourethropy, and the TRBT of these lesions.
Okay. So why my question is why do you want a TURBT? I mean it is very clearly CT3. There is indirect evidence of muscle invasion which is also staring at us. There is a right-sided gross cytonephrosis. I don't know about urine cytology, done, not done. But there is a normal creatinine and we have done a CT scan. Matlab, from the imaging, one thing I get very clearly, this is clearly muscle invasive disease.
Muscle invasion.
So if I have to give chemotherapy,
Yes, sir. Hydronephrosis.
I would go for a TUR and a biopsy. Like, I'm still not seeing that imaging so clear, but I think it is clinically over T3 image. That is what I'm saying.
Safety reports, sir, they have not mentioned anything like that. Here it looks like, sir, on the upper.
Here it looks like that. Nah?
Yes.
So what will you do?
The
There are
TURBT
two,
after
three
getting
possibilities.
extrapath
Chalo,
involved.
it comes, you do a cystoscopy TURBT. It comes
Yes.
urothelial and lamina propria positive, muscle not seen in your TURBT. Now what will you do?
Sir, after 2 to 6 weeks, I would like to do a restaging TURBT of this patient sir, as
Okay,
muscle involved.
no problem. ठीक है.
Sir, it is already CT is showing it has
नहीं,
gone
चलो,
beyond the bladder and
he is not saying wrong conceptually. Let us
yes,
be
sir.
with him. So don't waste 6 weeks for this kind of patient because imagine
Okay.
we were just seeing that it looks muscle invasive.
Muscle invasive.
So in case you want to still prove it by TURBT, go in after 10 days
2
or
weeks.
2 weeks. Don't waste more time.
Okay.
But here it looks say muscle invasive. So now what? Urothelial eye. What will you do?
Sir, if it comes out to be muscle invasive, then I would like to give a neoadjuvant chemotherapy to this patient with MVAX.
Neoadjuvant chemotherapy with, then you say if you want to give, then the dose dense MVAC is the best.
MVAX.
I have already put that Vesper study as a.
Vesper study, yes.
Okay. So that is one thing. But suppose you do a biopsy and it comes something like micropapillary, then
So if micropapillary variant comes, then we would have to go do a early cystectomy in this patient, as it is more aggressive. Early cystectomy in this patient, sir.
okay. तो और कोई क्वेश्चन इसमें है नहीं टेक्निकली.
सर
would your surgery? Yes, sir. Sir, कुछ पूछ रहे हैं.
Radiologically T3, is it going to avoid to take the biopsy, complete or incomplete? TUR. आपका जो मुझे कंसेप्ट समझा नहीं, इसलिए पूछ रहा हूँ कि रेडियोलॉजिकली अगर T3 है तो विदाउट बायोप्सी न्यू एडजॉइंट दे सकते हैं क्या?
सर हम लोग TMH में देते थे एक्चुअली. रेडियोलॉजी T3 का यूरिन साइटोलॉजी पॉजिटिव है तो दे देते. बट अ सेफ अप्रोच आई वुड से इज स्टिल डू अ सिस्टोस्कोपी एंड TUR बायोप्सी और अ सिस्टोस्कोपिक बायोप्सी बिकॉज आ सकता है वेरिएंट हिस्टोलॉजी. बाकी कुछ नहीं. So safe thing in exam is that in clinical practice you can take a call, but that is in clinical practice into inverted comma. And then it always depends on a presence or absence of a multidisciplinary tumor board, which is readily available in hospitals like TMH, Tata Memorial Hospital. And उसमें यूरिन साइकोलॉजी होना ही चाहिए पॉजिटिव, मतलब नहीं ऐसा नहीं.
And neoadjuvant now you are giving for T2 also?
सर मैं up to 60% पेशेंट्स को ऑफर तो करते हैं, because आजकल I think surgery has become pretty safe with all energy वगैरह usage. The blood loss is also I think less.
Very less.
हाँ, एनर्जी यूज करते हैं तो टाइम ऑफ सिस्टेक्टोमी इज ऑल्सो गॉन डाउन नाउ. पहले
Correct.
3-4 घंटे सिस्टेक्टोमी को करने को लगते थे, सिर्फ सिस्टेक्टोमी को अभी 1.5 घंटे में हो जाता है.
Yes. Ligashar use किया तो we just apply it and just the bladder is out within a
Yeah,
short period of time.
करेक्ट.
Earlier when nothing was there, we used to ligate
तो
everything
टाइम
and
किसको लगता है आजकल की अच्छा लिम्फ नोड डिसेक्शन करो ब्लैडर में,
yeah.
अच्छा सा रिकंस्ट्रक्शन करो, सो दैट टेक्स मोर टाइम नाउ. Destruction surgery of cystectomy, cystoprostatectomy takes less time.
Agreed.
I agree with you.
So
question is in this case as usual, suppose now what is the latest in MRI?
Wire scoring.
Can you avoid CT scan and can you just do MRI?
अरे पटपट बोलो, you must have read
Yes,
already.
sir.
Don't
Sir, if you
waste
are
time.
suspecting a muscle invasive, yes, sir. Muscle
ऐसा नहीं बोलने
invasive,
का.
sir,
See, your
MRI
answer
is
should be pretty
better.
clear.
So
MRI is
To differentiate
evolving.
T2 or T3 disease, sir. Can you use?
Never answer like that. Always when Gaurang sir जैसे examiner ऐसा सवाल पूछता है तो बोलो कि earlier CT was the standard, now MRI is evolving and has a good upcoming role. Virads, version, whatever you want to say, and it has its 5 grades, 1, 2, 3, 4, 5, and imaging can be with use of multiparametric MRI bladder. You can suspect tumor. Also, T2 weighted imaging shows the muscle layer more clearly, and breach of muscle layer is clearly seen in MRI. Although it is evolving, it appears to be that it is a much better investigation. Abhi, if you compare between CT and MRI, some things are very obvious. For a T4, remember what I'm saying, T4, CT हो या MRI हो, कुछ फर्क नहीं पड़ता है. T3 over T3, CT हो या MRI, कुछ फर्क नहीं पड़ता है. T2, CT हो या MRI, बहुत फर्क पड़ता है. MRI is evolving in this role. T2 फर्क पड़ता है, एंड देन T1 अगेन फर्क पड़ता है वेदर मसल इन्वेजन है कि नहीं. सो रोल ऑफ MRI कम्स, एक तो प्री TURBT imaging should be done, and in T1 and T2 wherever you want to differentiate. T3 and T4 both investigations seem to be same, but guidelines में आना बाकी है, तो you have to say that role is evolving in a positive manner. ऐसा बोल सकता है. So examiner will come to know that you know, you have read, and you are knowing something.
Please remember all of you, and this is nowadays I have seen many people are asking this question about MRI.
देखो
The other
when tumor, you feel when tumor is confined to the wall of the bladder, then MRI is comparatively better than the CT. And rest what sir has told. So if sonography, CT करना कि MRI करना, if sonography shows multiple tumor, if the size of the tumor is already 4-5 centimeter, then we have to go for something at least CT or MRI. If it is a small tumor confined to the wall, maybe probably T2 or less, MRI is better than the CT. And for rest, CT and MRI, as far as lymph node and T3, T4, they are both are same. Already sir has told like that.
Yeah. So one more question I want to ask them. Suppose if you do MRI and if you find out there is a muscle invasive, can you avoid biopsy? Ajinkya, Rahul.
Yes, sir.
No, let them answer. I'm asking them.
Sir, क्या question था?
तो क्या question?
If MRI is showing muscle invasion, will you avoid biopsy?
Can
Sir, if
MRI
cytology
avoid
is positive.
biopsy confined lesions? That's what sir is going to asking. Wall
If
confined lesions.
cytology is positive, sir, then we can, as sir said, we can go ahead with neoadjuvant.
Listen,
Sir, in
sir,
exams,
sir
biopsy.
asked a very specific question. Whatever Bakshi sir describe you in detail,
Yes, sir.
just Gaurang Shah sir just ask uh, the aspect of that. Ki now you
So
have
in
this.
case of virus, it is.
Hello,
Hello.
Mahendra. We
Yes,
can't
sir.
hear you.
Hello.
Yeah.
Yeah. So, sir asked MRI. So, basically, the MRI was not to decide CT or MRI. It is TURBT or not to be done for the muscle invasiveness. This was the where the role of MRI is evolving. If MRI can 100% sensitive about the T2 and T1, we can avoid TURBT and we can go ahead with the either neoadjuvant or the definitive treatment. So why sir is asking if MRI is showing T1 and T2, how will we proceed? Am I right, sir? Gaurang Shah,
Yes,
sir.
yes, yes. The same thing,
But
whether you can avoid TURBT, so
sir,
that if the cytology is positive, you may not take a biopsy and directly go for a treatment.
So Bakshi sir answered that already, that
Yeah,
evidence are evolving. At
evolving.
present, MRI cannot replace TURBT as per the present literature. Okay, if it is there, we have to do a TURBT to prove the muscle invasiveness. Maybe in future, MRI may replace TURBT or maybe equivocal to TURBT.
Okay, so fine. In exam, please remember and answer accordingly. Okay?
But you should know if somebody asks about the Virates, you should know 1, 2, 3, 4, 5. What is it? It is just like a Pirates, but have a
Yeah,
different implementations.
good. So final now, what you'll do in this case? Rahul, Rahul, what you'll do in this case? Let us finish now.
Sir,
I think, yeah,
yes,
yeah,
sir.
tell.
I would like to give him the neoadjuvant chemotherapy, reassess the response after 2 cycles, and then if it is complete response or partial response, I like to we'll go ahead with the radical cystoprostatectomy with extended lymph node dissection.
So the correct answer would be I will reassess the response by the
Reassess.
CT scan,
It is, yes, sir.
abdopelvis with the IVU. If it is complete response or partial response, we will give the full dose of neoadjuvant chemotherapy and reassess.
Good.
Why we do CT scan in between the chemotherapy? See the response. Why not after the completion of chemotherapy?
Sir, in case this is it takes around 4 weeks to complete 1 cycle. So if in case it is not responding and we still give 4 cycles, we'll lose some time of doing a radical cystoprostatectomy. And if it is showing response, we can continue with other 2 cycles.
And if it is not showing response, then
Answer. Don't worry. You're
Yes, sir.
right.
then it is straightforward. If chemotherapy is
Straightforward
not
radical
answered,
cystoprostatectomy, not
Radical
yes.
exactly.
Yeah.
Okay, fine.
1 week. Fine. Anything else?
That's what I am thinking, sir. What to ask after the neoadjuvant?
So just one drawback of that, sir. MRI doing first, matlab, showing muscle invasive, sir. Directly going for a neoadjuvant, sir.
MRI is not an investigation of choice at present compared to CT scan. If it is contraindicated, and if it is strongly, yes, Dr. Bakshi sir just put in the group a 100% accurate muscle invasion. Okay,
Yes, sir.
but what type of tumor they are? Like that have a small stalk having the broad base, okay, or overall nodular. How this thing? So you have to characterize which type of lesion it is, multiple, single, how accurate they are in single lesion or multiple lesion. Okay, so maybe I have not read that paper. So this you have to decide accordingly. But definitely at present, that role of TURBT cannot be underestimated.
So gradually it will evolve. As this paper is very good actually, you can read with that link, everybody. I mean, so VIRATS 4-5 conclusively tell us something. But again, you will have to do a TUR biopsy in these patients. We discussed that point of having urothelial versus variant histology. Okay, remember that. You can't, that's what I feel personally. You can't give up a biopsy at least. And VIRATS 3 is a equivocal thing where it is written, I just put in the chat, 2/3 only will be muscle invasive. So good 33% are not going to be muscle invasive. So accordingly, we can answer that question.
Yeah. Fine. Okay.
Okay, everybody, all the best.
All the best to, if we have time next Tuesday, if we get a good cases and if the exam has
We can do that.
not yet started, we will keep some cases. Okay.
So next Tuesday, मतलब वो थोड़ा सा exam के आसपास होगा सर उनके.
हाँ इसीलिए if they are willing, because no everyone's exam is not on
तो जिसका
9-10.
exam नहीं है ना Tuesday को, please put on the group, then we will come to know.
Gaurang Shah, sir, can I say something?
Yes, please.
Sir, now they are reading for the exam purpose. So when they are reading, having good discussion, they will have many questions about how to answer that.
तो चाहिए तो सिर्फ question answer कर सकते हैं.
Can we focus maybe 2 hours of all the जितने भी 40 participants, everybody have a different question answer. So if we just spend 2 hours giving answer of each individual person, that will be better to clarify their doubts.
No problem.
Nice. Good idea.
तो students आप लोग ये इसका comment डालो group में, then sir will arrange it.
Yeah.
Because क्या होता है कि we do everything and only 4 people come up.
Exactly,
So we want everyone to ask at least one question. So 35-40 candidates, they must come out at least with one question. They have got
That is a
doubt.
better idea, sir. Everybody should ask one question.
So if actually I was calculating, sir, for last I would say 2 hours, maybe we have asked at least 150 questions overall.
Right.
So in 1.5 hours, if we can answer 100 questions of individual question and they can satisfy their doubts,
it will be good. So
good.
okay. So let us put it on the board and then let everyone, at least 35-40 people come out with at least 1 to 2 questions and they can ask and we will answer that how to answer in exam.
And कुछ भी होने दो, I think across urology, let's keep it.
Anything.
Tell all your friends, okay? All of you who are attending today, tell your friends.
And
जिसका exam नहीं है, वो Wednesday को वो join हो सकता है.
Yes. Or even Wednesday वाला, what he is going to do at the last moment.
हाँ, last moment पे read करके कुछ फायदा नहीं होता है, but
in case
online
if there
तुम
are
join कर ही
chances that
सकते.
out of 150 questions, even some 5-10 questions comes and if he can answer well, he will be happy.
Pass हो गया.
Yeah. Gite sir will be there to pass them.
ये record मत करो.
Okay. Chalo. Bye. Good night.
Bye. Good night, everybody.
Thank you, sir. Good night, sir.
And all the best for those who are going to appear for exam.
Good luck to everybody.
Yeah, all the best.
Good night.
Thank you, sir.
पटना में मिलेंगे sir. Bye.
Yes, Patna mein tomorrow. Okay.
Many people will see in the flight only in the evening.
Yes, I will be meeting you.
Bye.
Bye.
Sir,
बोलो.
kindly end the session, sir.
And meeting for all, correct?
Sir के साथ है
Yes,
ना?
sir. Yes, sir. Yes, sir. Yes.